righty. Greetings and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Payne, editor for MS Focus, and I'm joined today by Dr. Richard Burt, who will present hematopoietic stem cell transplant for MS. During the presentation and afterwards, Dr. Burt will open it up for your questions and comments. Now I'm delighted to introduce our speaker. Dr. Burt is a Fulbright Scholar, Professor of Medicine at Scripps Health Care, and Professor of Medicine at Northwestern University. He endeavored for 35 years to bring the field of stem cell and cellular therapy to the patient's bedside. Hematopoietic stem cell transplant for MS and published the world's first randomized clinical stem cell transplant trials for systemic sclerosis and MS. Dr. Burt was recognized by Science Illustrated for accomplishing one of the top 10 medical breakthroughs for the next 10 years, and by Scientific American as one of the top 50 individuals, teams, or organizations for improving humanity and outstanding leadership. We're pleased to have him join us to present on this important topic. Dr. Burt, thank you for being with us, and I'll turn it over to you.
Well, thank you, Chris. Thank you, Deborah. We always have to start anymore by saying conflict of interest. And I think it is kind of important. So I want everyone to know I've never had pharmaceutical, big pharma support or precipitated in big pharma trials, never. I've never performed these HSCT, hematopoietic stem cell transplant. Hematopoietic means blood. It means a blood stem cell. I've never performed HSCT or blood stem cell transplant for a license, royalty, or a monopoly. All right. So I want to ask the first question. I want to do this in a Socratic method rather than didactic. And we may not be able to do that with the way this Zoom is set up. But why will HSC never transplant, hematopoietic stem cell transplant, never be FDA approved? Anyone want to ask or say that? Give me the answer. I guess we don't have time for that then. If I'm in front of a class or an audience, people can raise their hands and speak up. So I'll just ask questions. If you can get me an answer, I'll give a minute delay, otherwise we'll go on. Well, why will HSCT never be FDA approved? And patients say that, it's not FDA approved. Why won't the FDA approve it? The reason is there is no patent. That's the very first thing before a drug company will attempt a trial for FDA approval. They have to have a patent. Because if they don't have a patent and they do the trial, anybody else can go out and make their product. And they've spent all this money and other people are getting the profit. So they won't do it without a patent. And your own blood stem cells, thank goodness, cannot be patented. If someone can take your blood stem cells and patent them, they can patent your finger, they can patent your arm, they can patent your leg. We've gone through that in history. That's called slavery. Okay, so this will never be approved because there's no patent involved and there is no drug company money involved because they can't make money on it. So there's no corporate financial interest, government license, or monopoly. None of that. And that's what the FDA is designed to do. A company develops something. If they get approval, they get a government license, which results in a monopoly. And they can make a lot of money. Well, that's not the case here. This is also minimally manipulated homologous, which are FDA terms for the FDA doesn't regulate it. It's just like getting a blood transfusion. The government or company doesn't own it, okay? So that's why it'll never be FDA approved. But the result is there's benign neglect for this procedure, because our medical system's gotten very oriented towards an FDA-approved drug. So what I want to ask you about conflicts of interest, whose conflict of interest? Whenever you hear that term conflict of interest, always ask yourself, whose conflict of interest? I will swing back to that at the end of the talk to answer that, but think about it. So what is a hematopoietic or blood? It's blood stem cell. There's a lot of Latin and Greek in medicine and law. So, but it's a blood stem cell. okay? It is a multipotent adult stem cell. Multipotent means it can form many types of cells, but not every cell in your body. So the hematopoietic or blood stem cell forms the cells in your blood. That is your red blood cells that carry oxygen, your platelets that clot blood, and immune cells like T cells, B cells, macrophages. They got all these names. Dendritic cells, you don't need to know them. It's just your immune cells. Your immune cells attack bacteria, but it also attacks anything it views it as foreign. So if you get someone else's heart, it's going to attack it. And the people always have to be on intense immune suppression. Okay, so the blood stem cell will form all these cells naturally. It's multipotent. If it won't form a neuron. If it could, it would be pluripotent. That means forming many different types of cells. So I want to ask you, is hematopoietic stem cell transplant a neural regenerative therapy or an immune regenerative therapy? So again, I prefer Socratic method. Let the audience answer. If nobody's answering, I'll give or writing the answer, I'll tell you. It's an immune regenerative therapy. It's not neural regenerative. And there are many misconceptions about hematopoietic stem cell transplant for multiple sclerosis. The one misconception is a stem cell therapy. No, it's an immune-based therapy like all therapies out there for MS, okay? All hematopoietic stem cell transplants are the same. That's very common because the procedure is called HSCT. Anytime after you give drugs in which you give stem cells to hasten recovery, it's called HSCT. Because it's called that, everybody thinks it's the same, but it's not. The outcome of HSCT depends on the immune regimen you choose to get rid of the old cells and your patient's selection and experience in doing this. They are not all the same, just like not all drugs that you take are the same. Copaxone's not the same as Lemtrada or Ocrevus in terms of toxicity or efficacy. So why this confusion? Anybody want to jump in? All right. It's because language is imprecise. And when I look back at a lot of difficulties that arise in this world, whether it's within families or outside of families, it's not understanding the intent from the words. Language is imprecise. For instance, I'm going to talk about what DMT means, disease modifying treatment or therapy. What is that? What does it modify? Okay. When you say disease modifying therapy, which all the drugs are that you get, you think, oh, they're taking care of the disease. But it's not a very precise explanation. And HSCT is not precise. People think that's what's doing it. Your stem cells have no effect. They just hasten your recovery, but they do not otherwise have an effect. Okay.
On the subject of DMTs, we did get a question here from Aaron. Does this procedure work if you're on Ocrevus?
We have to stop it, but of course, we've done many people who've had Ocrevus, but we have to have a clearance of at least 4 months off the drug so you don't get PML. That's kind of a detail that can be discussed later, but yeah, it doesn't matter, you know, but we do have to get that drug cleared for horrible whole world relapse 3, 4, 5 months later. Because the half-life is said to be, you know, a week, but the biological half-life, the effect on the body lasts 3 to 4 months. Once that wears off, even though the drug's long gone, you can explode with a bad attack. So, but where you can also get PML. So the drug causes PML. It's a virus that can make you much worse or kill you. But yeah, we do it after Ocrevus all the time. But the imprecision of language is very important. It's why emails are really bad if there's miscommunication. They only continue miscommunication. You have to talk to the person in person. It's because when we talk in person or we see someone in person, we get a lot of other cues. We get the tone of the voice. We get the movements of the body. So we understand the words. It's why a dog actually communicates very well with us. They don't understand our language, but they understand our movements and the tone of our voice. We do that all the time, but because language in and of itself is very imprecise way to communicate. And it's one of the problems with internet and emails and texting is you miss all that important information in communication that you normally pick up when you see someone face to face. If someone says they love you and you look at them, you can see in their eyes and their body gesture, it's relaxed, it's open, they mean it, versus they're saying it, but they're being sarcastic. If you just hear the words and nothing else, you can't tell. So that's why there's confusion. Also, big important reason is neurologists do not know HSCT. They don't do the procedure. To them, it's all the same, like a transplant and cancer. And hematologists, oncologists that can do this procedure do not know multiple sclerosis. So that's why this, besides the fact that it's not a marketable drug that any company makes profit on, that's why there's confusion and what hinders the development of this field, despite phenomenal results that I'll show you. So I'm going to talk about background for MS and HSCT quickly, just in case, get everybody on the same page. And then development of transplant, HSCT for MS. I have to use the nomenclature, but it's not really a transplant, it's immune-based therapy. And the summary of these questions I'll be asking that, I guess, jump right in there if you have a question. All right, patients are incredibly intelligent, and when you suffer through something, you really understand it. If you're sitting on a couch looking at someone else, you really don't. So they do. And how patients describe things, I always find remarkable. This is Ann Romney, the wife of Mitt Romney, who had run for US president, who has MS. What she said, MS is losing who you are. I think that's a very good description. And what you get are these demyelinating plaques here. These are called Dawson fingers radiating out from the ventricles. Juxtacortical lesions are very common. Infratentorial lesions, especially in the cerebral peduncle, but in the cerebellum here, and then spinal lesions not shown here, and the infratentorial aren't shown either, just the periventricular and juxtacortical, but that's very classic for MS. What are these lesions? They begin as inflammation, leaking of inflammatory T cells, B cells, and macrophages across the blood vessel into the soft, spongy area of the brain where the neurons are, your myelin that wraps around those neurons, the oligodendrocytes that make it. It starts ripping the myelin off. You get inflammation, you get bare axons, and then they start getting transected and being cut back. They try to regenerate, they get transected. The end result is you get a scar. Your brain will form a scar, gliosis, astrocytes. They're the fibroblasts of the CNS. And that scar is hard. That's why it's called multiple sclerosis, multiple hardening. Just like a scar on your skin is hard. The normal brain tissue is very soft, but that's because the neurons are gone, the oligodendrocytes are gone, and you got a scarred tissue. That's what multiple sclerosis means, multiple scars in the brain, okay? That's because that's what they first found at pathology. It actually comes from Charcot-Marie Tooth, a French physician back, I think, late 1700s, early 1800s, who came up with the term. All right, there are different types of multiple sclerosis. So there is a clinically isolated syndrome. So you have one attack, very suspicious BMS, but that's it. And they'll call it CIS because you need at least 2 attacks to call it, it's disseminated in space and time is the terms that are used. But so once you start getting recurrent attacks, that's called relapsing remitting MS. And 85 to 90% of MS is here, this relapse remitting presentation. You relapse, you go back to your normal baseline, or you may relapse in your baseline. So this is neurologic disability getting worse as you go higher. Your baseline's worse, but your baseline between relapse is stable. You give it enough time, and what happens is the majority, which are relapse remitting over time, become secondary progressive. And you can still have a relapse. That's called active secondary progressive. But secondary progressive means your baseline between attacks is worsening. In relapsing remitting, it does not worsen. It may be worse than when you started, but between attacks, it's no worse. Whereas in progressive, your base neurologic function is very, very slowly worsening. You may still have an attack, or those attacks with time disappear, and your baseline just worsens without acute attacks. That's non-active secondary progressive. Or you can have primary progressive from onset, where the baseline just slowly worsens from the beginning. The baseline's declining. Relapse remitting, baseline returns to normal, may be worse than where it started, but you're stable to the next attack. So I want to ask you, what types of MS should be offered HSCT? Well, the answer to that question is HSCT is an immune or neuroregenerative therapy. It's an immune. So we want to attack this immune phase, not this late scarring phase, sclerotic, multiple sclerosis, astrocytosis, gliosis that the plaques become. We want to attack it here, relapse remitting. I wouldn't with HSCT. I wouldn't do it with CIS because it's too early in the disease for this type of treatment. We can do it in relapsing or active secondary progressive, but by that time you're really late in the game. You're not going to return a lot of function, and it means you've been failed. You've been given the wrong therapy for too long. It needs to be done here, like all therapies for MS. So misunderstandings in the field of MS and in the field of HSCT. Disease modifying therapy. What does it modify? Anybody, please. What you hear the term, all medical publications, all neurologists, all people will say, you're getting a disease-modifying therapy. The drug company is called a disease-modifying therapy. I want to ask you, because language is imprecise, what does it modify? What is being modified in the disease exactly? Anybody? All right. Hematopoietic stem cell transplant. Is it a stem cell therapy? No, it's not. The stem cells are given to help you recover from the conditioning given to get rid of your immune cells. But the stem cells themselves have no neuroregenerative potential. What is the difference between non-myeloablative and myeloablative HSCT? That's really important. If you're a patient, you're considering this, you need to know the difference between non-myeloablative and myeloablative, and I'll talk about that later. I only do non-myeloablative, okay? What causes toxicity for the drugs? Disease-modifying therapy and HSCT, okay? Anybody? Oh, by the way, this background is the field. So the field of MS and HSCT. Anybody want to answer any of these questions?
Let's see. We have Lacey who says DMT is to slow the progression of the disease.
They tell you that, and that's not really true. I'm going to go into that in a minute. Semi-true, but mostly not true. But excellent that you're bringing that up. By disease modifying, you're saying it's progression slowing. You can have an acute attack and then you recover. But the main thing is in between that progression, that decline in disability, that it's progression slowing.
Also, we had a follow-up question from Hannah regarding the Ocrevus earlier question. She asked, I also have a question about the risk of Ocrevus, HSCT, and PML. Can you spend any more time explaining that?
We can. Can you ask me that at the end? In basics, we've never seen PML in transplant. It has occurred with Ocrevus, but that's why we always have that break of several months, at least 4 to 5 months, off of Ocrevus before we'll do a transplant. We've never seen it happen. Doesn't mean it couldn't, but we've never seen that. But that's why we build in that break.
Okay.
All right. Any other questions?
If you'd like, I can bring this question back up at the end.
The answer. Yeah. Any other answers to these questions? Well, the answer that it slows disability, very forward thinking. You're thinking, what does modify mean? Let me get to that. So I'm going to ask this question again. Disease modifying therapy, what is being modified? The number of relapses, are those being modified? Disability progression, that is accumulative neurologic disability that's irreversible, is that being modified? Quality of life, is that being modified? And then NADA, and we don't really have time here to go into NADA. NADA means no evidence of disease activity. It means no acute attacks, no increase in disability, no new lesions on MRI. That's NADA 3. NADA 4 is also no atrophy in the brain, NADA 4. And we're just in this talk, won't have time to go in that. But for you, I mean, you don't look at your MRI, and what's important for you is, can you function? Are you normal? And your quality of life. Relapses, progression, quality of life. Are those modified? Well, I'm going to tell you right here, the modestly effective, they call them, this is the actual term, modestly effective disease modifying therapy. It would be much more accurate to call it relapse slowing therapy, because it absolutely does not slow disability progression. It just slows the number of relapses. Doesn't stop it, but it slows it. But you still progress in disability the same as if you didn't get this therapy.
We have
It's
answers
very
from Hannah
important.
and we have answers from Hannah and James, and they both reply the immune system is being modified.
By what? HSCT. I believe that was the question. But yes, so we'll get to that. I think, I'm not sure what the question was I asked when you said that, but what is being modified, the immune system being modified, but what in your disease course is being modified? It's slowing the relapses. That's all it does. It doesn't slow cumulative disability. And so the effective ones are the interferons and Copaxone, and they're usually given subcutaneous or intramuscular. They're called injectables. But even if you didn't took, and here are the randomized trials, those are the names, you can look them up on Google, they do not slow progressive disability or the accumulation of progressive disability. They just slow the number of attacks you have. What about moderately effective? They're still just relapse slowing therapy. That's, I think, a much more descriptive name than disease modifying, because it tells you what's being modified. Do you modify relapses? Do you modify accumulation of disability? Do you modify quality of life? The only thing of the three things I said is it modifies the number of relapses you have. It slows relapses, not disability, doesn't improve quality of life. Here are the randomized trials. Check them out. These drugs, the moderately effective, are generally given oral. And, these are the sphingosine 1 receptor phosphate or sphingosine 1 phosphate receptor modulators. They're all kind of the mode drugs. They all work by the same way. The fumarates, both of these work by the same way. And cladribine, that's a chemotherapy drug used in cancer all the time, but they give it for MS. But it's moderately effective in slowing number of relapses. Now, highly effective disease modifying therapy, I would call that disability slowing therapy. It actually will not reverse. It doesn't stop, but it will slow the accumulation of disability. These drugs are almost always given IV. Mitoxantrone, which is a very potent chemotherapy drug for cancer, it's approved by the FDA. Most people won't give it anymore. These are all monoclonal antibodies. Whenever you see MAB, they're monoclonal antibodies. And of course, all drugs have different names. So Tysabri is probably the name you use for natalizumab. Ocrevus is ocrelizumab. Kesimpta, even though it's a monoclonal antibody, can be given subQ. Otherwise, they're IV. These are the randomized trials. Okay, now there's a nice paper just came out in 2022 in JAMA Neurology, and they clearly say that none of these drugs, including the highly effective DMTs, will slow disability accumulation. It says that. But for me, reading these trials, I think the highly effectives do slow disability accumulation. But they don't reverse it, they don't stop it. Okay. Now, here's non-myeloablative transplant. What it does, it affects the immune system too, just like those drugs, but it's disability reversing therapy. That's a big difference. It doesn't slow disability, it reverses it. Okay. And the regimen I used for non-myeloablative cyclophosphamide rabbit ATG. It's given intravenously the cyclophosphamide called Saxon for 4 days, ATG for 5 days. These are the same days, literally. The randomized trial that we showed was called MIST, okay? So that's why I'm saying language is imprecise. Disease-modifying therapy, what does it mean? None of those DMTs reverse disability, improve disability, okay? And actually, none of them improve quality of life. Transplant does, and I'll show you that data. So this is the trial we ran, multiple sclerosis international stem cell trial. I was the head of it. There's no drug company involved, none, zero, no money. We did it. hard work. Nobody paid us for it. We got no money. And it was just academic centers to help humanity here in America, in the UK, in Sweden, and in Sao Paulo. All right, so here's the randomized trial. The neurologists were blinded on the outcome. So again, this just emphasizes what is being modified. For modestly and moderately effective DMTs, it's relapse slowing therapy. That's all that's being modified. And it's unending treatment that you're always on to try to slow the number of relapses. It does not slow accumulation of disability. For highly effective DMTs, and I mentioned the monoclonal antibodies that do that, it is disability slowing therapy, but it doesn't stop you from getting accumulated disability. And it's unending treatment. For instance, questions comes about Ocrevus, you stay on it. For HSCT, it is really an immune-based therapy. It's a disability reversal therapy. One-time treatment results in long-term stopping of relapses, stops accumulation disability, reverses disability when you're doing it in relapse-remitting MS, improves quality of life. It's a one-time treatment. All other therapies like antidepressants, stimulants, anti-anxieties, patients are able to get off of. I mean, you can't cold turkey an antidepressant because it can cause suicide, but people are usually on the antidepressants because of the disease. Once the disease gets better, they don't need it. Stimulants like Adderall, again, it's to the disease. They put them on anti-anxieties to slow them down because of the disease and stimulants to speed them up, and antidepressants. That's just covering up because you can't control the symptoms. After transplant, we're able to get rid of those. And the majority have long-term drug-free remissions. All right. Now I want to ask you, in these drug company trials, what was the control arm? Well, for modestly and moderately effective DMTs, it is relapse, which is really relapse slowing therapy. It's not called that, but that's what it is. The control arm was always a placebo or the weakest drug out there, an interferon. Okay. In highly effective DMTs, which is relapse slowing therapy, but also possibly disability slowing therapy, the control arms of placebo are the weakest DMTs out there. The first ones, the modestly effective ones, interferon and Copaxone. When we did transplant, we used the best available therapy. 60% got Tysabri, which was the strongest drug. It's a monoclonal antibody. It's a highly effective DMT, and that's what we compared it to. So I want to ask you, why don't drug companies use best available therapy as their control for approval instead of the weakest drug out there? Anybody? Well, let me ask this. How much does it cost a drug company to run a drug trial? It costs about $50 million on a drug trial. So no drug company is going to invest in it if at the end they don't win. And if you compare against the weakest, you're going to win. If you compare against the best out there, you may not be statistically better, and then you're not going to get approval. That's what it boils down to. The weakest opponent. You're not going to go out against number 2 in the field or number 1 because you may not win. I hope that makes sense. It's the way our system works. And it's, again, the imprecision of terms. Disease-modifying therapy does not mean curative. That's why you're kind of always on it. It doesn't even mean you're stopping disability or slowing disability. If you're slowing the number of relapses, and with highly effective, you are slowing disability accumulation, but not reversing or stopping it. And they're all based on comparison to the weakest drug out there, unlike what we did, and we get no royalties. So what is the mechanism? It's not a true stem cell therapy. It's an immune-based therapy. It's a supportive blood product. That's really what the stem cells are. It hastens your recovery. So what are the mechanisms? I show them here. Here's the modest and moderate DMTs, the interferons, which are modest and weakest. They just skew your T cell, its immune cell cytokine profiles, the kind of little proteins that are released by the T cells influence other cells. It just skews it. Copaxone, which is also a modest DMT, does the same thing. Once we get to these sphingosine-1 phosphate inhibitors like Gilenya and all the rest, Saposia, so forth, there's form, or to Aubagio, teriflunomide, we're talking about, in case of Aubagio, it can inhibit the proliferation of T and B cells, doesn't get rid of them, just slows how they'll proliferate. And the sphingosine-1 phosphate inhibitors like Gilenya, they just slow trafficking, which means they interfere with the cells to move around, but it doesn't get rid of them. The fumarates, again, just skew the T cell profile, but they're still out there. Cladribine, that's a chemotherapy drug used for lymphomas, and it can get rid of and disrupt your lymphocytes, but it's a potent chemotherapy drug, approved. It's called cladribine in chemotherapy world. They changed the name Mavenclad to treat MS patients like it's a different drug. No, it's exactly the same drug, just given a different name. But we never use the name Mavenclad to treat lymphomas or leukemias. We use the name cladribine, which is what it really is. Novatron is a chemotherapeutic drug that intercalates. It inserts itself between DNA, and it will then decrease T and B cell proliferation, but it can cause all kinds of damage to the DNA, and it's FDA approved, but fortunately, very few people use it, but that's potent chemotherapy. These monoclonal antibodies here, natalizumab, Bertisapri, alemtuzumab, Lemtrada, Ocrevus, so forth, they're monoclonal antibodies. Tysabri, it inhibits lymphocyte migration. It doesn't affect the T and B cells that attack you. It just stops them from into the brain, or B and NK cells that you have to recover from. Ocrevus, it only affects B cells. So notice most drugs are against T cells, a type of immune cell, whereas Ocrevus is really specific for B cells, or drugs get both T and B cells. So cyclophosphamide ATG gets rid of T and B cells with you get a lymphopenia, but you rapidly recover, you get an immune reset. That's the difference. These are all immune-based therapies. That's the basic difference in how they work. We give the stem cells faster. You recover about 4 days faster. Without them, you would recover anyway. So, immune-based therapy for MS. What is the toxicity? Again, outcome is based on the immune regimen you select, patient selection, and center experience. The toxicity for transplant is just exactly like a DMT. It's based on the drug. It's not based on the stem cells. Giving you back your own stem cells that we collect from your blood has really no toxicity. Okay? So if we look at toxicity of drugs, the interferons, they get ITP and hypothyroidism. There's a lot of things they can get. But what I want to show you, especially ITP, is where your platelets suddenly drop. You start bruising easy. You could have a really bad bleed, or even a severe bleed into the head that could take your life. And of course, you can get hypo and hyperthyroidism, and of course, very flu-like symptoms when you take it, sometimes disabling. So Copaxone, skin necrosis, flu-like symptoms, many other things. Aubagio can, hair loss and infections like tuberculosis, liver toxicity, but again, fetal malformation. Don't want to get pregnant on that. All these sphingosine-1 phosphate inhibitors, they can cause you to go blind, macular edema. So you need to see an ophthalmologist while you're on them. And why do they do that? Because that receptor is in your eyes. The receptor they bind, sphingosine-1 phosphate. It can cause bradycardia, AV blocks, cardiac arrhythmias. That's why when you start it, they monitor you on a monitor. It's because the receptor, sphingosine-1 phosphate, is in the atrium of your heart, and it can mess it up. But if 6 hours you're monitored, you do good, they don't monitor anymore. But I've seen patients come 2 years on Gilenya. We get an EKG and they're in atrial fib. It's the Gilenya. It's just not being monitored. It, of course, can cause hepatotoxicity, PML. That's a virus. And if they get it, will die, or they'll be significantly worse neurologically afterwards. Very wicked. It can occur rarely with these drugs. The fumarates, liver toxicity is an important thing. Cladribine, You can get infections, especially the herpes virus. It's very dangerous for babies. There is probably, because there is in cancer, it's not yet been shown in MS, but there probably is an increased long-term risk cancer. It's been shown no short-term increased risk, but cancer is a long-term thing from accumulated damage. And this, is a potent chemotherapy drug. But right now, no increased risk cancer, but we don't have long-term data. Mitoxantrone causes horrible cardiomyopathy that can occur late in myelodysplastic syndrome or leukemias and damaged liver, because it's a potent drug for cancer, and it's not specific to cancers of the immune system. It's used a lot where risk benefit justifies its use, because the cancer is going to take your life shortly if they don't do it. So you take these risks. But fortunately, neurologists have steered away from this drug, novantrone and mitoxantrone now. Tysabri causes PML, that viral infection. It's the worst drug to cause that. It correlates with the JC virus index. That's the virus causes PML, so they monitor that. If it gets too high, they have to stop treatment. When they stop, you get rebound severe MS. We call it tumefactive. It's so severe it looks like a tumor. Alemtuzumab can give strokes. That's a black box warning for that. A stroke, a hemorrhagic stroke because of dissection of your carotid arteries. And that happens. You can give PML, that horrible drug. It can give all kinds of other virus things, HPV, so forth. It can give autoimmune disease, especially ITP, where your platelets drop suddenly, hypo or hyperthyroidism, as well as anti-kidney disease, glomerular membrane disease, and a lymphopenia that, unlike transplant, just doesn't recover. It will persist, and it will be at the level of a HIV or AIDS patient. You're not getting the infections of an AIDS patient, but that's where your CD4, a type of lymphocyte we monitor in AIDS, will sit. It just doesn't recover, unlike a transplant. As a matter of fact, some doctors in-house will use the nickname liquid HIV for this drug because of that. Okay. Now, it won't give those infections we see with HIV, but those CD4 positive T cells result in those being too low to give those infections in HIV, because that's what the virus HIV targets, is those CD4 positive T cells. They are really wiped out by this drug, and they just don't recover. Now, anti-B cells, they only target the B cell compartment. And their biggest side effect, I call PIRA. That's progression-independent relapse activity that I'll come back to. Well, you'll say that's disease-related. It's not a drug-related thing. I think no, because it's imprecise words. We need to recognize this as drug-related. What goes on is it knocks down the flames, but the burning coals still keep going in the periphery of the lesions, and so progression continues, even though you're not having relapse or MRI changes. It's very deceptive. They'll get an MRI, you haven't had a relapse, your MRI looks the same, high fives, you get more anti-CD20 at $40,000 an infusion. But the burning embers are still attacking, and many years later, you end up with permanent disability. That's PIRA, progression-independent relapse activity. The drug most notorious for it are all these anti-CD20 ones, because they're not targeting the T cells, just the B cells. There's a lot of, oh, what causes PIRA? Well, that's what does it, and I'll show you that in a minute. You get very severe hypoimmunoglobulins. You need immunoglobulins to fight infections, so you get upper respiratory tract infections, UTI infections, so forth. You can get other side effects like neutropenia, thrombocytopenia. PML has been, again, and you stop it, you can get this rebound tumefactive MS. So finally, when you go with transplant, look at, are these toxicities really much different? The one thing is we do get cytopenia for about 8 days. All your blood cells are low, and you can get an infection. You shouldn't get an infection that takes your life, but you can't promise that won't happen. It would be very, very rare, especially with a non-myeloablative regression, but it could happen. That's in that period when you're in the hospital for about those 8 days. You'll need an occasional red blood cell platelet transfusion, not too many if you do it right. You can get side effects like ATG fever. If you avoid that fever, you don't need many transfusions. The late thing to be aware of is you can get ITP, just like you can with interferons. And we might tell people if they ever get easy bruising, check their platelets. It'll usually occur within the first 2 years. The latest I've ever seen is 3 years out. I know why it occurs. We don't have time to talk about it here. You can get hypo or hyperthyroidism and age-dependent infertility. Basically, under age 26, all women retain fertility afterwards. By age 32, 98% will become infertile. But for all women, we recommend, and men, that men's sperm banking, women oocyte banking. And why won't this go forward? Okay, so what is the difference now between a non-myeloablative, which is what I'm talking about, and myeloablative transplant, HSCT? Non-myeloablative, the infusion of your hematopoietic stem cells is optional. If we don't give them to you, you are going to recover just fine. It's just to take 4 days longer. So we give them because we want you out of the hospital sooner. We want less risk of infection. We don't have to give them. The blood counts recover without the stem cells, but they shorten your recovery of your neutrophils, where we can discharge to, you'll be discharged usually the earliest I ever had was day 7, the latest day 12, it's usually day 9. We target specifically your immune system with non-myeloablative, not your blood stem cell, which cancer cells will destroy. So it's much safer. There's no mucositis, there's a lot less infections or risk of transfusion. It's a safer approach. Whereas myeloablative regimens, which a lot of people in America now give, they use those cancer regimens. And if you don't give the stem cells back, you're going to die because it will destroy the stem cells. It's not immune specific. It's used for cancer. Leukemia is a stem cell problem, so they want to kill the stem cell, but that's not what we want to do with MS. And it has greater toxicity. Well, I think they hope because it's so much stronger that you're going to have greater benefit, but nobody knows the risk benefit with compared to a non-myeloablative. The problem is when you say transplant, everybody thinks the same. No, the outcome and the toxicity is going to be very different between non-myeloablative and myeloablative. This is cancer. Matter of fact, the regimens used are cancer regimens. I'll show you. This is a regimen I use. These are non-myeloablative regimens used to treat autoimmune disorders of different kinds, not just MS. I use this one. It's the most common one used worldwide because I developed it and I've talked around the world. Most people use it. Anti-thymocyte, globulin, cyclophosphamide. Those are the doses. Other people use cyclophosphamide, rituximab. These are both T and B cell targeting with a transient cytopenia, lymphopenia, and then you recover. These are myeloablative. They're much more aggressive. Beam, that's a lymphoma regimen. Bu-Cy, ATG used in Canada, that's a leukemia regimen. And this is a standard lymphoma regimen. You get mucositis. They're much more toxic. They're much more expensive. By the way, I will tell you, transplants is $125,000. These will be $300,000. Much more expensive. They're not known, they're more toxic. They're not known to be more effective. In fact, who knows? They may even have significant worse effects in terms of damaging neurons. You don't want to use a regimen that could damage neuron. Now, I don't know if anybody will ever do a trial comparing a myeloablative and non-myeloablative regimen. I doubt that'll ever happen. But right now, we've completed this randomized trial. It's highly effective. Okay, remember, toxicity depends on drugs in your regimen. Just like the toxicity from DMT you get depends on the drug. And myeloablative are more toxic and expensive. Here is the myeloablative regimen we give. Cyclophosphamide, ATG 0.5 and then 1 and then 1.5 for these days. Cyclophosphamide each day for 4 days. Your stem cells, you start GCSF. And usually day 9, you're discharged. Day 8 or 9, you're out the door because you're recovered. Okay, my history of developing this. Well, I'm not going to discuss this today because it'll take forever. The reason I'm telling you is this idea just isn't something we pulled out of a rabbit's hat. It was a lot of work. It was 10 years of preclinical animal work in animal models of MS, EAE, and TMEV, and learned a ton of immunology and learned a lot about MS doing that. I do hate working with animals. I'm actually an animal rights activist by my heart, but to develop something like this and take it to humans, you have to start with animals. 10 years there is where I was. Our first clinical trial was a failure. We used a myeloablative regimen, including TBI, and it was secondary progressive MS. It did not work. I put in the title of our publication, failure, so I wanted people to know it would fail. The reason we started secondary progressive, because by the time you get late secondary progressive, nothing works, so neurologists would send you patients, and my NIH committee monitoring what I was doing said that's where you had to start. But my animal data said it wouldn't work there, and indeed it didn't work. And I wanted people not to know it doesn't work there. start there. And but unfortunately, that's what a lot of people do, because hematologists, oncologists don't know MS, and neurologists don't want to refer until they have nothing left to give, and it's late secondary progressive. And then this procedure, which is immune-based, is not going to work when you're no longer immune-based and you're purely neurodegenerative. So we reported that in blood. Now, if I'm going to move this into relapse remitting, I had to use a much safer regimen, got rid of the radiation, don't like that anyway. We used 2 immune-specific drugs, and we had great results reported in Lancet, but we got a high incidence of ITP. And it was due to alemtuzumab, because alemtuzumab gives ITP. So we had about a 14% incidence. Nobody died, but I was just worried it could happen. Someone would ignore easy bruising or blood when they brush their gums or something. I know I would keep working and ignore it, and then they could have a lethal cranial bleed. So we had to come up with a different regimen, and we did. We changed alemtuzumab for AT. It's a known side effect of alemtuzumab. By the way, when you're on alemtuzumab, they like to check your CBC every month or 2 months or 3 months for your platelet count. But I'm telling you, because it's ITP, it's really rapid. I've had a patient who got this alemtuzumab Cytoxan. We saw him, everything's fine, the CBC is fine. A week later, actually 6 days later, they call easy bruising, check the platelet count. It went from normal to a really super low, dangerous level where they could have a spontaneous intracranial bleed. We treated it, recovered. So monitoring your platelet counts every month, 2 months, or 3 months, I think it's comforting to the doctor, but it's not really comforting to what this does, how alemtuzumab can cause ITP, because it can happen really fast within a few days. So just be aware of that. Our third clinical trial, in ATG, we did 154 patients, and we had stunningly good results. That's published in JAMA 2015, Journal of the American Medical Association. I can't talk about that today, but it was the basis for what we're going to do today. And that was, we found the right regimen for a clinical randomized trial versus the best available there. And then afterwards, after I showed that data quickly, I'm going to talk about real life experience where we reported everybody we did on and off study. Because doing a study is a little bit of an arbitrary scenario. You have very defined criteria. The people walking the door may not have those criteria, but they may still benefit from the treatment. And so reporting everybody is a really important thing. Journals like to report only trials, but real world experience is very important. And we published that on everybody. And then the health economics, which I'll bring up next. Okay, so this was our randomized trial. So here's where we started. The neurologic disability, 10 is dead, 0 is normal. So the higher the number, the worse your disability. And we see that they're very similar coming in. Actually, the people who went to transplant had a slightly worse neurologic disability, but by 6 months and 1 year, look how much better they were. Lower number is better, 0 is normal. Less than 2, you're walking down the street, you won't notice that they have any abnormality. Okay, the DMT on the other hand, and we switched to like highly effective DMT, unlike drug companies that give the weakest DMT out there or nothing in the early days as their control. So we switched, but look at their neurologic disability got worse. Exactly the opposite. This was highly significant. And when we looked at time to disease progression, this was our transplant arm, this was the DMT arm, time to first relapse, transplant arm, DMT arm. These p-values were highly, highly significant in favor of transplant. There's a lot more in that article. I don't have time to go into it, but this non-myeloablative regimen stopped and relapses. It reversed and decreased disability and improved quality of life. And none of the drugs, the highly effective, especially, most of them got natalizumab or Tysabri, which is a highly active or highly effective DMT. Those drugs did not reverse or help disability. In fact, got worse, and they didn't improve quality of life. And I'll show you that in a minute. And with Cytoxan ATG, they're short-term toxicity you have to watch for and you can prevent. I mean, you will get hair loss, but it grows back. You need to block Cytoxan nausea, you need to block ATG stick fever. But if you can do that, the patients can be pretty much bored going through the procedure, maybe 1 or 2 tough days, and then everything tends to be better. Late toxicity afterwards, infertility, ITP, we can still see it, but about 2 to 3%, much less than when we used alemtuzumab. We do tell patients always, if they get easy bruising, get a platelet count, let us know what it is. Most of the time, it's normal. They've overreacted, but I'd rather have that happen than ignore it. And they're drug-free. They get better, stay better, no evidence of the disease, on no drugs. 76% are drug-free by 5 years, 24% relapse by 5 years. All right. Now, this is a real life scenario. That was the trial. This is a real life scenario, 507 patients we did, and they had relapsing remitting and secondary progressive. Now, why would I do secondary progressive? I said I wouldn't do it. Well, late secondary progressive, I won't. But what happened? We wouldn't see someone if they had secondary progressive, but their doctor's notes said it's relapsing remitting. They say it's relapsing remitting. They're not being dishonest. The doctors tell them it is. We evaluate them and realize they're in secondary progressive MS. But because we made that diagnosis and it appears they've turned into secondary progressive within the last year or two, and we went ahead and on compassion basis did a transplant. It really didn't help disability. Maybe you can argue slightly, but it didn't. The lower the number, the better, compared to relapsing remitting. 414 relapsing remitting start 3.9, end up 2.3, marked improvement. No drug does that. Secondary progressive 93. These were newly diagnosed by us. They weren't late secondary progressive. We wouldn't do them. If we'd known they were secondary progressive, we wouldn't have even seen them. But again, that's how secondary progressive comes about. It's often diagnosed 3 years late. It's a retrospective diagnosis. Because you can see the patient, they change, but when you look back 2 years earlier, they've had a slow, very gradual decline. That's secondary progressive MS without attacks. All right, so, but if we took this group and we looked at, since if they're active secondary progressive, which means within the last year, they still had a new lesion in their MRI. We did point MRI didn't have any evidence of enhancing lesions over the last year. It made no difference. They didn't improve them. 58 non-active and 35 active. If we looked at just all the relapsing remitting, again, there were like 414. The EDS, when they came to us, remember, 10 is dead, 0 is normal, and these are really high numbers up here, but you can see they still get much better as long as they're relapsing and remitting. And in fact, although maximum improvements at 1 year, here they keep, it's not unusual to keep seeing some improvement out to 5 years, gradually, still getting better. And you're on no drugs, nothing during this time. Okay, now it is not without death. Nobody can ever say they can do transplant without death. Non-myeloablative will have a lower risk of death than a myeloablative. It's less toxic, but you can't be in a hospital where there's a lot of sick people and a lot of things going on and a lot of high technology without something bad happening. We had a patient die from Legionella that got contaminated in the water supply. We found it in the patient's sink and in their shower head. It took the patient's life, and then went back and looked, and there were like 10 patients that had gotten Legionella in the hospital. It was just thought that they'd come from the outside, but in fact, they've been contaminated in the hospital. It was just very unfortunate that it was mine who died from it because of going through a transplant. But that's what can happen in a hospital. One before getting a transplant from sickle cell had a crisis and passed, and so by intention to treat, we'd have to say that. But we can do it very, very safely. You can never, I promise you, never do transplants your entire life, do like 1,000 or 10,000 and not have a mortality, because hospitals are dangerous places. But it's very low. But again, I read everybody a riot act so they understand. Relapse remitting MS, HSCT, not only is the only known treatment to reverse disability, we had marked improvements from 1 to 2.5 on the EDSS. No drugs ever done that. And it's the only thing that has improved quality of life. Well, if you get better, you get off drugs, your quality of life is better. Now, in active secondary progressive, I don't want to do it there, but it can still have some marginal benefit. But if we're treating you here, we got to you too late. You weren't notified, you weren't told, you weren't referred to us, which is very common. And, we're not going to make you as well as up here, okay? But we can still help you. Non-active, we can't help. Now, I want to talk about the health economics of transplant versus DMTs. Neurologic disability, best way a neurologist monitor it is called the EDSS. It's a neurologic exam. No evidence of disease activity, which means no relapses, no new lesions in MRI, no progression of disability and quality of life, as well as cost. And we published this. in multiple sclerosis and related disorders. Now, if you look at the EDS improvement, this is an improvement, okay? We have, up here to, 1.8, 1.6 EDS improvement. And this is 1 year, 2, 3, 4, 5 after transplant. One treatment, you're done, no more drugs. And you can see the sustained improvement. Now, most drugs have absolutely no improvement in EDS. They don't even report it. The highly effective ones have tended to report it, not all of them, but Tysabri and Lemtrada have. And they say, well, the EDSS is slightly improved, the disability, but in fact, the improvement is less than 0.2. It's often 0.1. They don't show long-term. And that improvement, this EDSS scale, the minimal change is 0.5. So for any one patient, that's no change. To record a difference, you need at 0.5. But when you do large numbers of patients, you do the statistics, you have thousands of patients, you divide by the number of patients, you get a change in EDS of 0.2, which is not significant for any one patient. Whereas look after transplant. These numbers are highly significant for patients, marked improvement in neurologic disability that is sustained. If we look at NADA, no relapses, no progression, no new MRI activity, that is enlarging or new lesions or enhancement, transplant, non-myeloablative versus drugs. Drugs don't report beyond 2 years. But if you look at their 2-year results, their NADA is around at best 50% with ocrelizumab. The others are less. The lower ones, interferons, are about 30%. Okay, that's at 2 years. But look at transplant, our NADA, going out to 5 years. This is 5 years. So 1, 2, 3, 5 years. There is one, Harvard at Mass General just looked at everybody, real world, not a drug trial, just everybody they treated at Mass General for MS, no matter what the drug was. They would change drugs for what they think is in the best interest of the patient, as you would normally do as a doctor. If you have a toxicity to one drug, you stop, you go to another one, whatever. But they show that the NADA by 5 years is only 15%. Compare that to over 80 with transplant. And they show their NADA, that's any drug they're using, is really equivalent to fingolimide out here at 2 years. But again, drug companies don't report long-term NADA, okay? If we look at quality of life, SF36, that's a very well vetted standard quality of life questionnaire that people fill out. Well, most drugs, DMTs that are approved by FDA, have never reported quality of life. The reason they don't report it doesn't get better. The highly effective DMTs generally do, like Tysabri, Ocrevus, and Lemtrada. And what they show is an improvement early on. Most of them don't show long-term now. Lemtrada did, but Ocrevus and Tysabri did not. But they show less than 5-point improvement, really a 1-point to 3-point improvement. That's what they're all showing. Again, the problem is you have to ask the question, what's a minimal change in this number over here to be clinically significant for a patient? That is, what is the minimal number change for a patient to realize there's an improvement in quality of life? And this has been used for so many different diseases. Everybody knows it's 5 points. If you don't have at least a 5-point change, your quality of life is no different. So these are no change in quality of life. This is a statistically significant number of a slight improvement, but it's a mathematical number that has no meaning in this real world, because for a patient, that change means nothing. You won't feel an improvement in quality of life. It has to go up by at least 5. Look at what transplant does. The other is the SF36 looks at your physical quality of life, mental quality of life, and total. And we always check all of it. For some reason, Tysabri only did physical and mental, not total. I don't know why they don't report that. Ocrevus only did physical. They didn't do mental or total. I don't know. Is it because the numbers are negative? They just don't report it. And Lemtrada only did physical and mental, and they didn't do total. But I mean, you should get all this information out of doing an SF36. In fact, you do. So why they don't report it, I don't know. Now, what about cost? Here's these drugs when they first came on the market. The interference with the first 1993. Look, 19,000, 13,000, Copaxone, Glatiramer acetates, $12,000 a year. That's what you were paying. Look at them out here now in 2020. They're much more now. We're in 2024. Wow. But in 2020, look, they're $100,000. And that's because as every new drug comes out, the new drugs, as they come out each year, are more expensive. And so these older drugs match the price. They just go up in the same price. Whereas a non-myeloablative transplant's 125,000. Well, if you're on interferon, you're paying 100,000 as of 2020. You're paying more now. Look at how it's going up. I mean, if you get a transplant for 125,000, 5 years, 6, 7, 8, 10 years later, you're on no drugs, never got back on drugs, you're doing better. That's a credible savings of over $100,000 every year to you or to your insurer or to our society, to the government, who's ever funding this, but somebody's paying it. That's an incredible savings. That's like $400,000 in 4 years saved, okay? Because you're off drugs. Whereas here, you just keep paying them. Now, be careful. Non-myeloablative transplants are about $275, $350. They're 2.5 times as expensive. Not myeloablative, the cancer ones. So again, I've always said you need to do non-myeloablative. It's so weird. When I first started this, I was the one that advocated for it. I did the animal models. Everybody thought I was too dangerous, too toxic. Now, people are rushing ahead with these cancer regimens, which I am saying are too dangerous, too expensive, not necessary, too toxic. So it's really interesting how the world changes. So I want to ask you, why do drugs increase in price each year 5 to 10 times the annual inflation rate? Anybody want to say why? It's because drug companies have FDA approval, they have a patent, they have a monopoly. With monopoly, you determine the price. Okay, the drugs we use in transplant, your stem cells, there's no FDA approval. They are yours. Nobody else should own them. The drugs that we use have long lost their patents. Nobody interested because anybody can use them and design it and make them cheaper. So, you know, our prices stayed fixed 100 to 125,000 ever since I started it. These drugs, you see how they go up, but they have a monopoly. Now, Copaxone, this one, it had hit 100,000. It lost its patent, and in 1 year, it dropped from what 90, 100,000 to $40,000. And so that's probably the real cost after you pay the cost of current production and make a profit selling it, because they lost their patent, and then anybody can produce it. But that's why. Now, they put a lot of time and money in developing things, and they want to get reimbursed, and I understand that. On the other hand, I developed transplant for an immune disease, non-myeloablative, with 20 years, 10 years first of animal work, 20 years of clinical trials. We get no royalty. We just did it to help society. We get no money out of it. Okay, I want to talk about this PIRA, progression independent of relapses. Patients use common sense. They call it smoldering disease. So what I had noticed when these anti-20 drugs came out, like Ocrevus, Kesimpta, rituximab, whatever, they decouple your progression, disability progression, from acute attacks and MRI changes, which is really weird because they usually kind of run together. And so the patient will have no MRI changes, no relapses. Everybody gets a high five. You stay on your Ocrevus, you're getting in, you know, one infusion, 2 weeks later, another infusion, 40,000 each for a couple-hour infusion. That's $80,000. And then every 4 to 6 months, usually every 6 months, you're getting this infusion. It knocks your B cells down. But many years later, you have irreversible disability using a cane or a walker or in a wheelchair. And it's like, what happened? And I've talked to some older neurologists, say 100% of their patients on Ocrevus after many, many years are like that. Some of the younger ones say, oh, it's about 30%. But this is a real issue. And you know, what is going on? I'll tell you what's going on. What causes PIRA? Progression independent relapse activity. Anybody? It's debated among neurologists, but I'll tell you what. The progression continues always. So if you pathologically look at these sclerotic, hard, you know, multiple hard lesions in the brain at autopsy, you have sclerosis in the center. You have an inactive lesion, which is late secondary progressive. The edge is just very sharp. There's nothing there. But in these other lesions, the edge still has macrophages, T and B cells, and is still destroying myelin at a very low level. And there's iron deposited there in microglia and macrophages. And that's the coals still burning. The embers are burning. The inflammation, the destruction still going on is just very subtle. But that's why you end up with that late disability, where if you use a treatment that stops that, and because when you get rid of B cells, which are only 4% of the cells in the rim of those lesions of the immune cells, it's only 4%, but they present those silent antigens and you get a higher fire out of the T cells and macrophages. Without it, it just smolders, but it keeps burning. So that's why. Okay. So, and I was very frustrated because neurologists aren't reporting this. And so am I hallucinating? But finally, out of Europe, there's a paper in Lancet by Maggie et al. I think it's Lancet Neurology, not Lancet, maybe Lancet, just came out this August. And the title is B cell depletion therapy, like Ocrevus, does not resolve. It doesn't stop. It doesn't resolve. It doesn't hinder chronic active lesions. Chronic active lesions are those lesions where the rim is still burning with inflammation. Okay. And that on MRI is called paramagnetic rim lesions. The reason it's paramagnetic is because the iron in there from the inflammation. In an old silent lesion, there's no iron, there's no immune cells, but that's what's going on. And so more importantly, I started taking these patients on Ocrevus who still had symptoms. They were complaining, my symptoms never went away. But because the MRI is unchanged, or they're having some worsening symptoms, they just keep on Ocrevus. We have taken them, done transplants, and their symptoms get much better. So that's kind of the proof.
I'm
my
afraid we're going to have to wrap it up. We've run out of time.
Well, let me say quickly, my philosophy is time is brain burning. You want to do transplant early to avoid PIRA. You want to do it as safe as possible, non-myeloablative. You want a regimen, of course, treats T and B cells. Doing a transplant, physician experience counts a lot, okay? Let me just go on, and I want to show you this at the end. You don't need to re-answer all these questions. This, for more information, this is a medical textbook, 686 pages, 140 professors, associate professors. I'm the lead editor. This lay book will answer a ton of questions. We have an educational website. We don't ask for money. There's not an opportunity to talk to us because we never have time to talk back and forth. It's just educational, a lot of educational information there. This book will really help you to understand. It's really profiles and courage of patients, as well as explaining what I talked about today. The forward, we were blessed by, done by the Dalai Lama. So again, changing a field and history of a disease and a system depends on patience, commitment, persistence, and one step at a time. I am working now with a true pluripotent cell that can form any cell in your body. It's called IPS, working on another book called Kill Switch. We are continuing, I continue to do transplant in La Jolla. It's such a beautiful location for the patients and so safe. Hopefully my last paper in MS, because I'm trying to switch over to IPS for true repair of damaged tissue instead of just an immune reset. But hopefully my last will be long-term, because in writing this book, I just randomly talked to patients by random 20 years post-transplant, and they're still doing great. Got better, stayed better, no more drugs. And so I should really look long-term follow-up. I put in a grant to pay for patients to come back to get an MRI, to examine them, pay for their hotel. The funding agency wouldn't support it. That's what's been holding me back, but I'm persistent. If I can get a grant that would fund my patients for an airfare and a night in a hotel, so we can get the formal evaluation of their very long-term 10, 15, 20 years follow-up. Because just by randomizing people, I was stunned because, we lose touch with them after many years. We give longer follow-up in drug companies, but we lose touch. And I was like, because our patients come from all over the country, all over the world, every state of the 50 states. So hopefully I'll be able to do that. But in this book, here's a review by His Holiness Dalai Lama, by the President of Northwestern, by U.S. Senator Mark Kirk from Illinois. And it's available on Amazon or Barnes & Noble if you want to go and get it.